Welcome. So my name is Harry Quilter-Pinner. I'm Director of Research here at IPPR. It's my absolute pleasure to welcome you here this morning for this really exciting event, which is launching the first interim report of our Commission on Health and Prosperity. This launch has been a huge amount of work in the build-up, so we're delighted to have got to this point, and we're delighted that you are here to share this moment with us and hear about the work that we've been working away at. Today's paper, Healthy People, Prosperous Lives, sets out, I think, a relatively simple argument that our nation is getting both sicker and poorer, but those trends are linked, and that if we can drive better health, we can also drive a better economy, and that shift is not only just necessary but also possible. We believe that this report is one of the most comprehensive recent studies into that link between health and prosperity in the UK, and it sets out also a really ambitious set of institutional reforms in how we make policy in this country to try and help us achieve both better health and greater prosperity. And we hope that it is part of a growing conversation about this issue, particularly as we emerge from the pandemic. How can we create a more healthier and resilient society? Before I kick off with today's proceedings, I wanted to just say a huge thank you firstly to our amazing team at IPPR, and in particular Chris Thomas, who heads the Commission, and Carsten Jung, our senior economist, who's led on the analysis for this work. But obviously it's also a much wider team effort of our media, publications teams and research teams. So thanks to everyone who's been involved. I'd also like to thank our amazing commissioners. We have just a small selection of them on the call here today to speak about this this report, and it's an absolutely amazing group of people to bring together, and I think the creativity and the rigor in this work is testament to their commitment to holding our feet to the fire and making sure that we come up with some powerful and useful conclusions. In particular, I'd like to thank Dame Sally Davies and Lord Aradazi, who are our co-chairs, Sir Oliver Letwin, who's also on the call, and Clare Bambra, Professor Clare Bambra is also on the call. And finally, I'd like to thank our funders, AbbVie, Alzheimer's Society, AstraZeneca, British Heart Foundation, BMS, Janssen, Impact on Urban Health, Gilead, and GSK, without whom we would not be able to do this work. So I think that's enough from me. I'm now going to hand over to Chris Thomas and Carsten Jung to introduce the key themes from the report, and then we'll hear from Dame Sally Davies, Sir Oliver Letwin, and Professor Clare Bambra. So first over to you, Chris and Carsten.
Great, thanks, Harry. I think we're just going to talk through some of the results and some of the key policy recommendations to give us some context, and I'm going to hand straight to you, Carsten, to talk us through some of the key findings.
Great, thanks, Chris. Hi, everybody, good morning. I'm going to introduce for 5 minutes some of the key findings of the report. I'm going to jump straight in. So the baseline we start from is that as a nation, we're suffering from high rates of illness as well as high rates of inequality of illness. So on the left-hand side in the chart, you see the rates of chronic illness and the rates of being at mental health risk. And you can see that from 2014 onwards, we've gone from about a quarter of people suffering from a chronic illness to an increase to about 30% of people suffering from that. So a steady increase, and this has been going on even from before what's in this chart. Similarly, people at mental health risk on a steady incline, and this has been further gone up throughout the pandemic to 1 in 5 people suffering from mental health. On the right-hand side, you see that this is not an equal opportunity menace. It shows those two rates of chronic and mental illness by income quartile. And it's quite a stark difference. So if you're in the lowest quartile of earners, you have almost half chance. Every other person in the lowest quartile has a chronic illness. And this, by the way, isn't just people of older age. This is the working age population and affects many young individuals as well. And the rate of those in the first quartile is almost or is more than double than those in the highest quartile, both for chronic illness and mental illness. So high rates of illness and high inequality of rates of illness. The next thing we look at is how does this impact people's economic lives? Next to being a personal catastrophe to have some of these illnesses, it can also have a huge impact on people's economic lives. And we analyze this through regression analysis, a statistical analysis, tries to tease apart the effect of illness from the effect of other factors. And what we look at is a pre-pandemic period. So this is 2015 to 2020. And then we look at the pandemic specifically. So the 2 years, 2020 to 2021. And we ask if somebody falls ill with either a chronic illness or a deterioration of mental health, how does that impact their labor market income? And we control for statistically, so we tease apart other factors that might have caused this. So what was your previous income, level of education, where you live, ethnicity, and a few others, such as to isolate the effect of falling ill on income. And we find that in the pre-pandemic period, the effect of chronic illness was about 1,800 pounds earned less at the end of the year, and the effect of having a mental health deterioration was about 2,200 pounds earned less per year. And the majority of this can be explained through the exit from employment effect. So these are averages, but for many people, when they fell ill, it meant they left work altogether, or if they were already out of work, they were less likely to re-enter work. So that's an important effect, but also for many people, it meant working fewer hours. So they would be earning less over the course of the year. As you see in the top right, if you aggregate this up, this is actually a huge cost just from foregone labor market earnings to the order of 43 billion pounds annually, or about 2% of GDP in 2021. In the report, we delve a bit deeper into the different channels. And again, we build a statistical model that estimates how illness affects labor market exit. And again, we split this by pre-pandemic and pandemic period. And here again, we split it by income quartile. So on the left, 1 means you're the lowest quartile of earners, 4, you're in the highest. And what you see here is that 1, again, you see the inequality. Not only are poorer people more likely to be ill, they're also more likely to exit. And then illness comes on top of it. So if you're, in the lowest quartile, about 9% likelihood of exiting, regardless of whether you're ill or not. Whereas in the highest quartile, it's more 7.5% likelihood of exiting. And then if you fall ill, you have a significantly higher chance, about 4 percentage points higher likelihood of exiting. And what's quite stark on the right-hand side is that the pandemic exacerbated this. So higher income people were actually less likely to exit work than they were outside the pandemic, whereas those on low incomes were significantly more likely to exit. And chronic illness and chronic illness made it even more likely for them to exit than the impact of illness on high income people. Next, the impact of mental health is really striking, and it comes out in the UK household longitudinal survey that we use throughout this to analyze people over time, so following the same people throughout the periods we study, which allows actually for quite a precise estimation of the effects we look at. And we find that mental health has a significant negative impact on people that are still in work. So of the entire working age population, almost half say that mental health somehow affects their work. It means they accomplish less. But if we look at the people that I showed you earlier, those 20% that have poor mental health, for them, virtually all say it negatively impacts their work. And a third of those say it impacts it most of the time or all of the time. So a real drag on productivity coming through mental health. Now my last slide, and that is hinting at the solutions, and that there could be, on the flip side, a positive impact if we boosted health, because it could boost income, but it could also address inequalities in the economy. So in the report, we outline a scenario in which we cut rates of chronic and mental illness by about 10 percentage points. And we model this in a way that it would improve in proportion to those, it would improve relatively more for groups that have higher rates of illness and mental health prevalence. But all groups would benefit, but just those groups would benefit in proportionately more. And we see that on the left-hand side, this could address regional inequalities. So it shows the average income improvement due to this health boost that we model. And you see that in Wales, for example, average real incomes could improve by about 1.8 percentage points. Still a very huge boost at the bottom in London by about 1 percentage point. On the right-hand side, we do the same for gender. So women have higher rates of chronic and mental illness. So they would benefit by almost twice as much as men, about 2 percentage points, a real income boost, whereas for men, it's just under 1 percentage points. So have a look at the report. We play this through for other inequalities as well. So ethnicity, for example, we could see improvements of inequality there, and a few others. So do have a look. Thanks for your attention, and over to Chris.
Brilliant. Thanks very much, Carsten. And I suppose what this says to me is that we know that health has an innate value to happier lives and a social value. Here it adds another case for doing it, another string in the bow of the arguments that we have, the prosperity bow. And what you'll see in Carsten's analysis is the matchup of some of the big economic challenges that we face, while health could be a useful solution to some of those. And so the question becomes, and this is the thing I want to talk through, what do we do about it? And we had a choice, I think, going into this report. That choice was either list the interventions that we know work, or to think a little bit more deeply about why change doesn't happen. And I think what struck us in making that decision is that a lot of the policy is out there, a lot of the evidence base is out there. In many ways, we know what works, what could create a healthier and therefore more prosperous UK. Those things are contained in, of course, the academic literature, but in independent reviews. We've seen the National Food Strategy, we've seen obesity strategies, we've seen the current review of making smoking obsolete. You know, there are transformative ideas out there that could make a difference. The problem, the kind of root cause of the challenge we face, I think, is that we don't necessarily have the impetus, the will, the sustained progress that we need to make transformative difference. And so that's what we look at. And there are examples of other agendas that have gone from a position where progress is not the default, where it's not the expectation, to a situation where it is the expectation. And one of the best examples of that, though by no means a silver bullet, is climate change following the Climate Change Act in 2008. What that framework did quite powerfully is a couple of things. I think the first important thing it did is it set the mission. It enshrined in legislation a definition of net zero. We can, and there have been changes to that definition. We can debate those, but put a definition in law. and there was cross-party kind of support around at least that definition going in there, albeit some disagreement about the ambition. The second thing it did is brought in the right institutions. It created the right government architecture, and things like the Climate Change Committee to take a statutory footing, to have a very set role in holding government independently to account. Very powerful. And third thing it did is make it everyone's business. It wasn't just a mission of government. It wasn't just a mission of individual choices. It was something that everyone could do, a sector by sector mission that included the private sector and others as well. And so our recommendations in the report today are anchored in that. Why don't we treat health, given the value that we're ascribing it, why don't we treat health a little bit more in that way? And so we set out those same things and start to map out what they would look like for health. So in the first case, thinking about what health net zero looks like, so suggesting a national aspiration of making the UK a genuine world leader on health, and then tackling some of the inequalities that Carsten's talked about by bringing the health in each English region, each UK nation, to at least the state retirement age, but ideally beyond it. The second thing then is making sure there's the infrastructure to make that happen in practice. And to this end, there are three things. The first is the 30-year mission. Brilliant, but that needs to be broken down. Missions are only deliverable if they're broken down into tangible bite-sized chunks. That happened in the Climate Change Act with carbon budget, so we suggest very similar for health, that we need that mission breaking into 5-year intervals with a clear evidence base, a clear kind of what's a cost-effective path proposition to go alongside that. Then you need the right institutions to come alongside that, on which we suggest two. So the first, the health equivalent of the Climate Change Committee, to define what our trajectory to that pathway looks like, to hold to account, to provide an independent presence. We lack an institution in the health sector with a statutory footing in the way the CCC has, and with clear independence so that it can be trusted across political parties as well. So a facilitating and accountability body there. And further an evidence body, a what worked centre to drive an evidence revolution in the places where at the moment we don't have that curation and evidence creation, including the return on investment and cost efficiency proposition. So a recommendation that's been made in some guises, including Nesta work on the Nightingale, but something to bring the kind of rigour of NICE, but to the prevention and to the public health agenda as well. And then the third thing, and this may be slightly different, thinking about the things that follow the Climate Change Act rather than the things that were involved, is that the investment streams need to be right. So if we're talking about things where there's a return on investment proposition, then there needs to be capacity, institutional capacity to make those investments. So we suggest a health creation fund that's a more strategic fund than what we have at the moment. I mean, at the moment, we have a public health grant that's essentially service funding. It's ring-fenced, but it's also mandated. We don't have strategic funding that allows us to find the best opportunities for both health and prosperity. So a health creation fund would give us at a place level much more agility in the opportunities that we take up. And of course, because not everything can be achieved by government, what we're talking about is a cross-society mission. We also need investment streams that can support what's happening in the private sector and in the real economy. And that's where our recommendation of a national health bank comes into its own. The idea behind that would be that there needs to be, and where there are at the moment, there's good results, there needs to be sources of patient long-term capital for products that can be disruptive, that can be innovative, that can compete with markets that are currently dominated by unhealthy products, including markets where those products have become unhealthy over time, soft drinks and processed food. There are examples like Lucozade of things that were created with good intentions that have changed in impact over time. So our ability to invest in the new wave of healthy products and to make sure that there's real competition and markets aren't closed, that feels like a very important way to make sure that we're pulling all the levers that are available to us. Ultimately, what that package is about is suggesting a framework, suggesting the right infrastructure to make change happen, to make change the default. It doesn't mean that the policy choices don't then matter. The policy choices then matter immensely, and that's where the Commission now turns to. From the position of progress as the default, what does the character of that change need to look like? So I'll leave it there as a summary. I'm sure we can get more into it in the Q&A, but hopefully that gives some context from both the results and the policy sections of the report released today. I think I'll pass back to you, Harry.
Fantastic. And I'm now going to hand over to our co-chair of the Commission, Professor Dame Sally Davies, currently Master of Trinity College, Cambridge, and former CMO for England, to talk a bit about the origins of the Commission and the work we're doing and the big arguments we're making. So Sally, over to you.
Thank you, Harry. Do you know, it's exactly a year to today since my co-chair Aradazi and I launched this commission on health and prosperity with the IPPR. And at that launch, we set out the commission's central hypothesis. One, I think we all innately believed, and it is that a fairer country is a healthier country, and a healthier country is more prosperous. Carsten today has presented the most comprehensive evidence out there that this is actually true. And it's really shocking information. Indeed, the findings Carsten has just shared suggest that good health could be the antidote to many of our economy's pressing challenges. Persistent low growth? We find that better health could boost GDP substantially. Significant challenges with economic inactivity in the UK labour market? We find that good health is critical to economic participation. Historic falls in household income? Our research finds that good health supports earnings and household income. So let's put it simply. Good health is the medicine our economy desperately needs. But perhaps what strikes me most about today's analysis is that by choosing a methodology that tracks individuals over time and traces what happens to them if they fall sick, gives us so much more insight into the personal economic costs of sickness. When someone falls ill in the UK today, they find it harder to earn money. At a time of great financial insecurity and cost of living pressures, they find it harder to stay in work if they're ill. Those who stay in work see their job satisfaction decrease. These are the kind of things that findings presented solely in terms of either GDP or labour market participation rates are liable to miss. So behind the headlines on the economic cost of poor health sit these catastrophic costs of illness on individual lives. So I argue we need to use this knowledge to inform policy for action and impact, to improve people's lives and our economy. The knowledge underscores why it's so important we transform our nation's health. So how can we do that? I don't think we'll get there by continuing to pretend the NHS can do everything on its own, or by doubling down on the idea health is an individual issue of responsibility, agency. Surely the only way we'll change things is if we make health everyone's business and put in place cross-society mission to transform it for the better. We can do this, but it's going to include going beyond NHS and individuals. It needs to think about the role of all of government, all public health services, the role and responsibility of business, I'm not letting anyone off, of trades unions and workers and communities and civil society too. This is about all of us. And you might say this is ambitious, but each of these groups will find in today's commission paper a reason to care deeply about our health. From a business perspective, we see the impact of poor health on jobs and productivity. Actually, ONS data reported today confirms that again. From a worker perspective, we see the impact of sickness on earnings, pay, and the ability to get meaningful, enjoyable work. And thank you, economists, you're going to spot the impact health has on macroeconomic indicators, on the UK's domestic product, and on the overall health of our UK labour market. So it's clear better health relies on everyone playing a role, but it can also benefit the whole of our society and economy, because it's not just about money, it's about well-being. And to get there, we all have a role to play, but we all have something to gain too. And as I've often said, including in my book, Whose Health Is It Anyway, with Johnny Pearson Stuttard, health is our most untapped opportunity for prosperity and happiness in this, the 21st century. How ambitious could we be? Well, other countries have shown what's possible when we get serious about health. Having been the least long-lived country in the mid-20th century, Japan became the world's healthiest. That's a remarkable transformation. We can do it. More recently, South Korea has added nearly 6 years to healthy life expectancy at birth since 2000. We can do it. If the UK was to achieve the same rate of improvement, we'd likely be the world's best performer in 3 decades. So that's the level of ambition this, our IPPR Commission report, calls for. Let's strive for the UK to be the world leader on health in the next 30 years. But as it stands, we all know we're going backwards. Healthy life expectancy went backwards in the latest data covering 2018 to 2020. That has to change. We need to be ambitious as a society. If today's commission shows us the opportunity why health has such a potential to be the driver of happiness and prosperity, it will now turn to work on what a mission should look like. And we will explore going forwards through the Commission and IPPR work how the state can be strategic in pulling all the levers available to it in delivering good health. We're going to explore how government should work with business and innovators in partnership to solve some of these wicked health challenges. So we need an ambitious government and a structured approach. After all, previous attempts at anything like this have failed. We've been holding conversations across the country to understand the role of communities, local government, and place. And we'll launch a new plan for the NHS and adult social care to optimise their contribution to healthy lives and national prosperity. Before bringing together a full blueprint for health and prosperity in the UK in the final report of the IPPR Commission next year, it's going to be the most comprehensive and ambitious agenda for health since the Beveridge report proposed universal healthcare. I'm really excited about the diverse group that are working with us on this. Our commission and commissioners reflect the full diversity of the coalition we need to really deliver change. Representatives from business, unions, civil society, economics, epidemiology, and place. They've come together because we all have this broad realization that the moment for change has to be now. Our economy, our society, our individual lives have rarely been in greater need of good health. And following the pandemic, it's really had such public and political salience. So thank you to the IPPR team and the commissioners. Also, thank you to all of you who have joined us today to hear more about the research. We're looking forward to working with all of you on this journey in coming months as we go forward. Thank you. Back to you, Harry.
Thank you, Sally. I'm now going to open up to the wider panel and 2 of our other amazing commissioners. So first, I'm going to come to you, Oliver. Sir Oliver Letwin is the former Chancellor of the Duchy of Lancaster and the former Shadow Chancellor. Oliver, over to you.
Thanks, Harry. Well, Carsten and Sally have said almost everything that needs to be said about the report. I just want to dwell for a minute or two on 2 particular aspects of the report and its importance as things currently stand. The first of those is the labour market, to which both Carsten and Sally referred. We've all been talking for as long as anybody can remember about the need to spend money to have better health and a fairer society. What this report brings out is the need to have better health in order to have a fairer and more prosperous economy. But that's an abiding fact. I think that analysis probably will hold good for as long as people are people and society is society. but at this very moment, Britain faces a really quite challenging problem in relation to the labour market, which is that for various reasons with which those listening may or may not agree, governments have decided both to cut off labour supply from the EU and to operate a pretty restrictive immigration policy. And of course, these things may change over time, but the current prospects suggest that for a considerable time at least, we're not going to be able to import labour to make good shortages. And we have an enormous number of vacancies in the labour market, which aren't just a statistic. They mean that all sorts of things that we could be doing in Britain and things which would be helping the economy and reducing inflationary pressures are not being done because people aren't doing them. And what this report brings out is not just the fact we've all known, which is a very large number of people in Britain have withdrawn their labour or partially withdrawn their labour from the labour market over recent years, partly, of course, because of COVID and its long-dated effects, but as Carsten's figures showed, going well beyond that. But also, this report brings out that actually, if we took the right kinds of actions, we might be able to help a very large proportion of those people back into the labour market to their own advantage, because being healthier is much better anyway, but also to their own economic advantage, because being more employed and employed for longer will give them higher incomes, and also to the advantage of a country which desperately needs that additional labour at present. So the point I'm trying to make is this report is very timely. It's not just saying something that's in general true and is going to be true for many years and has been true for many years. As Sally said, we've all known there are problems here for a long time. We just haven't got around to doing something about them. But just now, it's particularly salient because of the labour market problems we face and the change that we could bring about in that labour market by making our population healthier. But the second thing I wanted just to bring out is that I think the points that Harry began with and which Sally has emphasised about the questions that governments ask and the focus that they have are really important. What I repeatedly found sitting in cabinet committees discussing policy was that although obviously the specific discussion about the specific matter might lead to different kinds of answers on different occasions and different circumstances, what really mattered was the questions that people were asking, because that sets the whole tone of the discussion. And if people are asking the right kinds of questions, they may still arrive at wrong answers, but they're a whole lot more likely to get to answers that are good answers than if they're not asking the right questions in the first place. And we have built in, as Harry originally pointed out, and Carsten and Sally have expanded on, a considerable degree of the right kind of questions into our policy making as a nation across different administrations with things like the Climate Change Act. So it's now pretty difficult for government to ignore the effect of policy on emissions, carbon emissions or greenhouse gas emissions. And the question keeps on being asked just in an automatic kind of way. Anytime a policy comes up, someone in Whitehall, someone around the table of the Cabinet Committee will ask, what is going to be the effect of this on carbon emissions? I don't recall the same kinds of questions repeatedly and institutionally coming up about what the effect of the policy is going to be on the nation's health. And that would be a big transformation to achieve. And I think what this report is essentially saying is that if we want to do something about the general problems of ill health causing lack of prosperity, and in particular about the labour market, which is such a salient issue at the moment, we have to institutionalise the question, what will this policy have as an effect on public health? And if we were able to achieve that through some of the mechanisms the report suggests, I think that would be a very significant step forward for the country. Thank you.
Thank you, Oliver. And last but by no means least, I'm going to come to Professor Clare Bambra, who is Professor of Public Health at Newcastle University, and I should say has done some of the most comprehensive and compelling work on the questions in which this report deals and that we are talking about today. So delighted to be joined by Clare. Over to you, Clare.
Well, thank you, Harry, for that kind introduction, but obviously worth saying I had done the most comprehensive work until today, where Carsten and the IPPR team, I feel, have, you know, stolen my thunder, but in a really, really great way. So I will just start off by just saying that from an academic perspective, I think the quality of the work is really high. It's used the best quality data that we could get, which, as Sally said, is looking at individuals and tracking what happens to them over time. A lot of previous research has looked more at areas, so it's a more general model. So it really was an immense amount of work that Carsten and the team have done on this, and I think it's provided us with a really comprehensive analysis, but also really excitingly, I think, is the way that the team have transformed that knowledge into really ambitious and clear kind of calls for policy action at different levels. And I think the idea of trying to have health as an emergency on the same level as climate is something really that we as a public health community can get on board with. The research that Carsten's done is also reinforced by what we know from other countries. So whilst there's not been much done within the UK looking at individuals over time, we do have research from countries such as Sweden, which has also found similar patterns in terms of labour market exit for poor health. Not to the same degree as us because of different policy measures that are in place, but just to say that this work is reinforced by what we know from other literature. I will just reflect a little bit. One of the findings, there's so much in the report and I do recommend that you read it. One of the key findings from my perspective, being based in Newcastle, is the regional differences that Carsten's analysis has found. It's particularly concerning, of course, that the Northeast and the North in general has much worse health than the rest of the country, and that some of the individual impacts of poor health on labour market performance are particularly exacerbated in the North. It's harder for people to get back into work if they have a health condition in the North, and when they do, they tend to have lower wages than similar people in the rest of the country. We did some work a couple of years ago, which found that around a third of the productivity gap between the North and South of the country is due to a higher rate of poor health in the North. So I think the solutions that the team have come up with could be a particular benefit to us in the North, as Carsten's analysis of potential income impacts that better health could have were obviously higher for people in the North. I think there are also some concerning issues if we look at general trends, and I think these are alluded to and suggested by the changes over time. Britain was becoming the sick man of Europe again before the pandemic, and it's clearly been exacerbated, as this report shows. Other work we've done has also shown a big increase in terms of mental poor health amongst young people, and we can also see this in terms of referrals to mental health services. These are our current workers or our future workers. So when we look at this analysis, it's not just about older people retiring early, it's also about the health of our future of the next 30 years. On top of that, we have the challenges of an ageing population and the potential need for all of us to work longer. So this means that the prevention of poor health and improving health across the life course is urgent and possibly more urgent than ever. The team have done really well in suggesting this huge ambition around the climate change comparison. And I think we can see that improving healthy life expectancy in all of the regions so that people are able to be healthy until their retirement age is a really tangible way of getting people on board with that. What needs to be done is obviously going to be at different scales. We need a national strategy that's cross-departmental and, as Sally has said, cross-society, with everyone buying in and playing their role. I think there needs to be a cross-party political consensus and commission on this in order to really address the continuing issues of poor health and health inequalities across our country. But on top of that, You would go down at different levels, looking at the evidence about what might be needed in specific circumstances. So it may be, for example, that health impact assessments could be applied, as Oliver was saying. We look at the economic potential of a policy. We need to think about the health impact of a policy as well. But also for people who are currently struggling, we need to be investing more in support for them. So, for example, condition management programs that can help people self-manage and self-care, but also involving labour market advice, adaptations and support. Much of our labour market policy towards people with a disability or a long-term condition over the last 15 years or so has been much more stick than carrot. And I hope that this research and the policy alliance going forward under the Commission will help us to think a little bit more about the supportive measures and interventions that we can do from a health community perspective, but also across other parts of society. So thank you very much to the team for this important piece of research and for the compelling arguments and ideas that it adds to this debate.
Fantastic. Thank you to all of our speakers and to the team for presenting that research, and I hope everyone found it enlightening. And you can, as many of the commissioners said, you can find a huge amount more detail in the report, which is on IPPR's website. Fantastic. So I'm now going to come to the audience. There's a Q&A function that people have started to put their questions into, so please do add to them as we go. I'm going to pick a couple of these to kick us off. So we have a question from Joe Farrington Douglas from the Health Foundation. Do these work exits include early retirement, or are they just work exits due to illness? Are early retirees likely to be wealthier, hence the pension age tax changes, or is this a red herring? So the question here really about whether this is a health effect or an aging effect and how those two things interact. And there's obviously been lots of research on this. So I might come actually to the team and to Carsten to take that one in a second. There is a question here from Richard Gardner looking at the mental health impact on productivity. What do we think we can do to try and truly deliver parity of esteem between mental and physical health? And then a third question, which is how this the health agenda links to the levelling up agenda, both in terms of its architecture, but in terms of its the kind of policies that we've seen the government announce on levelling up. So I'm going to take those three first. Carsten, can I come to you first on the question of how this interacts with retirement and the labour market exit statistics, and then I'll come to our panel to talk about both the mental health agenda and the levelling up agenda.
Sure. Thanks very much, and great question. Let me actually quickly show a chart from the report that answers exactly this question. So this chart shows for people that fell ill this is the pre-pandemic period, where did they and that exited work, where did they go? So this is ill people leaving work, and on the left chart shows people under 50, over 50. The right-hand chart shows people under 50, and indeed you see that for people over 50, about a third would enter retirement. I should say though that this is early retirement, so we constrained the age such that it would be people going into retirement before they're 65. Of course, 65 in some ways shouldn't be the necessary an obvious time that everyone retires. People could work longer, so you could draw the line later. But still, this is only a third. So a lot of people that fell ill, reported themselves as long-term sick or disabled when they left work, and still about a fifth, 20%, entered unemployment or marked themselves as unemployed rather than retired. This changes significantly when you look at people under 50. So about a third reported themselves as unemployed. And again, about a fifth said they were long-term sick or disabled. So there is an early retirement story, but especially as you, but by no means exclusively, even for the people over 50. And for people under 50, it is mostly an unemployed, long-term sick story. Okay, thanks very much.
Thanks, Carsten. Sally, I might come to you first if you wanted to come in on either of the kind of mental health agenda or on the levelling up agenda, and then I'll open up to the panel.
Okay, well, I think it's interesting to look also into the chat. Thank you everyone for contributing. And let me pick up first that I absolutely agree, occupational health really matters. So great that with the Faculty of Public Health, you're working on that. But also highlighted is Lord Stevenson's and Paul Farmer's review of mental health in the workplace. And this brings us back to understanding what is the role of the NHS, which I think is to treat sick people at the moment, and also to develop ways of doing things. But if you have mental health problems that are depression and anxiety, mild to moderate, then actually there's plenty of experience of intervening at work and supporting through work and at work. And I think we need to really start to roll those out much more. And I think it's not only in the individual's interest, but it's very much in the interests of the companies and businesses as well. Interesting to bring up levelling up, because of course, we all want it to happen, but it seems to be more of a framing and a phrase rather than real action. And so I would say that we've tried to put health at the centre a number of times. The Child Poverty Act did it, the Health Inequalities Strategy in England, and then the Healthy Aging Challenge, which turned into levelling up, and we haven't succeeded. And that's why we've not only got to have an ambitious goal, but we've got to be ambitious about how we make it work. And we do need some top-down approach, which could well meet, as someone has made the point, a bottom-up approach coming up. But we need to embed this with a statutory basis that moves it forward, and climate's a good model. Thank you.
Thank you, Sally. On the question of levelling up, I might just come back to Clare at this point, just because so much of your work, Clare, has looked at not just the national, the national picture of economic impacts of health, but some of those regional impacts which you mentioned. And I wondered maybe if you could unpack a little bit more about what your research shows about both the potential for health to drive or narrow regional inequalities, and the nature of those kind of health issues, how they differ across the country.
Certainly, thank you for that opportunity. I mean, colleagues probably know that the health in the north of England is significantly worse than the rest of the country, and that we were worse hit, for example, by COVID deaths and hospitalizations. At the moment, there's around a 2-year life expectancy gap between the north and the south of England, and we can see even bigger differences when we're looking at things like healthy life expectancy, which is how long you can be expected to live in good health, something which is of course fundamental and links into today's report. The work that we've done with the Northern Health Science Alliance has been looking at the impact of this poorer burden of health in the north on the productivity. So there's a famous statistic showing that the productivity gap between the north and south of England is around £4 per person per hour. And our analysis found that around a third, so £1.20 an hour of that gap, was due to these higher rates of poor health in the north. So we could have a significant improvement on the productivity of the north, and therefore the productivity of the country, if we address these health inequalities. So by making the health of the north the equivalent of the average health of the rest of the country, we could gain over 13 billion in productivity. I wanted to just link into the levelling up mission around healthy life expectancy and reducing inequalities in that by 2030. It's a brilliant and extremely ambitious, as I know Sally will concur, in terms of trying to shift that pattern so quickly from an epidemiological perspective, but nonetheless, ambition is to be welcomed. I think what's disappointing, and as Sally alluded to, is that there actually doesn't seem to be anything being done in order to try and meet that ambition and to fulfill that mission. At the moment, it feels like it's an aspiration. It would be quite nice if we managed this, but it's not reinforced and underpinned by strategic action. Sally mentioned the National Health and Equality Strategy that happened in England from 2000 to 2010. This was a set of policies that was implemented across government, so not just healthcare, not just the NHS, not just Department of Health. I think what Carsten's report has really shown, hopefully to a wider audience than us in health, is that actually health is everybody's business, and to achieve better health will have benefits not just for individuals, but for the whole country. In order to be successful in that, we need government to understand that it's the business of each department of government and their associated groups and businesses, etc., that they work with. But this is something that I do think is achievable, perhaps not by 2030, but certainly within a 10-year frame. If we were to do sustained policy action across different parts of society, then we could expect to see significant improvements within a 10-year period. That's what the previous evidence suggests. Thank you.
Fantastic. Oliver, did you want to come in on either of those questions before we move on to the next round of questions?
Yes, so just two things I wanted to add to what's been said already, one about mental health and one about regional levelling up. On the mental health front, I mean, there's been plenty of evidence around for several decades now, following Richard Layard's groundbreaking work 3 decades or so ago, that provision of sufficient quantities of talking therapies, at least those talking therapies that have been shown in repeated, very rigorous trials, actually to work in relieving mild to moderate depression and anxiety, for example, do actually produce, would actually produce a very marked improvement in mental health. What this report again demonstrates is something I think we already knew, which is that if people can be brought out of anxiety and depression, they are more likely to go back to work. This report actually shows numerically what that's likely to do. What this report brings out, which had not been really very much talked about, is that that would have a very significant positive economic impact. So the transformation that we're really seeking here is from discussions in government about whether we can bear the cost of increasing talking therapies to a different discussion, which asks a different question, which is, can we afford not to increase talking therapies economically and fiscally? And that's the kind of transformation we're trying to achieve in general. It wouldn't be a case of aiming that specifically at increasing parity of esteem for mental and physical health. But if you invest an awful lot more in talking therapies and you get a whole load of people out of anxiety and depression, you are actually diverting resources, if you like to put it that way, into mental health rather than just repeatedly into physical health. And in the meanwhile, you're improving people's lives and getting people back to work and improving the economy, and it should pay for itself. So that's a very important part of what this report is really about. So far as the levelling up agenda is concerned, in a way, it's an analogous situation. Recent governments that have been talking about levelling up are not the first to have done this. As Clare pointed out, there's been a long sequence of discussions about this over a very long period, and many policy initiatives have been undertaken by succeeding governments over many decades in the UK, and indeed while we're at it, in other countries, to try to improve reduce regional inequalities. And generally, they have not been very successful. And And I think the important point about this report's contribution to that is that it's not saying that we should have a regional policy on health, so much as saying that if we had a policy on improving public health, that would be very likely to have a very positive impact in terms of levelling up regional inequalities, which people like Clare have been pointing out for a very long time, have, and this report emphasises, have a very high degree of health causation. So if, for example, we were to take seriously as a nation the problems engendered by obesity, which Sally has been talking about for a very long time, and which successive governments have talked about, and which nobody has been willing to take the political risk of actually trying to do something about on a serious scale. But if we were to try to do something serious, that would have an impact on public health. It would have an impact on the economy. These would be positive. As a matter of fact, as this report shows, it would have a much greater impact in those regions which are most adversely affected by ill health at the moment, and are, as it happens, also the regions which are most economically challenged. So the important point I'm trying to bring out from this report is that you don't have to have a regional policy in order to have a regional effect. You can have a health policy in order to have a regional effect. And that's quite a major shift in thinking.
Thank you, Oliver. I'm now going to open up to the next round of questions. Do keep popping them in the chat. I think we'll get another round after that as well, if we're lucky. So there's a couple of themes that are coming out across a couple of these questions. The first theme is about the balance of collective action versus individual responsibility on health. So there's a great question from Ben Wealthy, which is pointing out the political aversion in lots of places to the idea of the nanny state, despite polling showing that actually action from government to reduce things like alcohol and smoking harm and obesity, action on obesity is popular, the individual policies are. And the question is, how in the lead up to a general election can the public health community persuade politicians of all parties to drive bolder change? I guess a bit of a warning, Oliver, I might come to you as the politician on the panel to say a bit about that. There's a linked question further down from Guy Taylor. Does the report discuss how to incentivize and motivate individuals to tackle their own health issues? So the kind of the inverse of that question, and what's the balance between those two things, I think is an interesting theme for us to pick up on. And the second theme that keeps coming up in these questions is about the role of the NHS. And we're very clear in the report that whilst the NHS is a vital institution, it's got a limited set of levers to be able to drive better health at this kind of macro level. But I think it's still worth discussing the role that the NHS can play and what levers it does have. The question here is first, how do we manage the NHS through the current pressures whilst also shifting to a focus on prevention? And there's also an extended question in here from D. Humphreys on, in particular, how ICSs play a role in helping the NHS coordinate with the wider state, other wider public services in order to drive better health. So I'll come first, I think, to Chris actually, maybe to take on the question on the NHS, because I know that the Commission is just in the process of doing a big piece of work on the NHS, but also we're doing some work with ICSs on the ground in partnership with NHS Confederation. So Chris, maybe if I ask you to kick off the debate on the NHS, I'll then come to the panel on both the question on the NHS and also the question on personal responsibility in the nanny state.
Brilliant, thanks, Harry. I maybe have 3 points to make on the NHS. The first is a flag for another smaller Commission report that was released a couple of weeks ago, but indeed showed that the NHS can be a powerful enabler of course, health and prosperity as well. The NHS's impact on this isn't going to be even the majority, but it's still significant because there are a lot of people that are living with long-term conditions now. So the impact of treatment is there. You can quantify that. I think the second thing that is worth saying is the Commission's then looking at that very closely. I think there are two timeframes for the challenges that we want to address. The first is what you do about the pressures now. It's almost a circuit breaker moment for the NHS in terms of how hot it's been run, how kind of lacking in resilience there is, and I suppose that drives a kind of status where actually running the NHS that hot is perhaps the most inefficient, economically invalid, and kind of in the long term most unsustainable way to do it. So we're engaging with that quite carefully. And thinking through what are the things that you would need to do in terms of a immediate then through to long-term NHS reform agenda to make sure that we're maximising prosperity, maximising health, and doing so in a way that means that health doesn't and the NHS doesn't kind of run out of sustainability, run out of public support in the long term. And I think that will implicate things like shifting into the community, that will implicate things like really having a genuine prevention agenda, all stuff that the Commission will think through and come forward with in the next couple of months. And then to turn to the integrated care system agenda, I think there's a lot of promise here in terms of thinking through ways that in a less siloed way that we can start thinking less about activity and more about outcomes. So I think there's lots of promise there. I think at its most promising, it's where integrated care system are working as, I wouldn't say necessarily anchor institutions, but what I think NHS Confederation have called anchor systems. So thinking about how within the forum of an integrated care system, there can be coordination around the different people that brings together to maximise health and prosperity, and to think about where different interventions can be aligned, how duplication can be prevented, and where people can work together and genuinely collaborate. I think that's at its most powerful. We're working at the moment with 4 integrated care systems and 1 health board in Wales to understand some of those dynamics more, collaborating with the NHS Confederation. So again, it's something that we want to work through as a Commission, particularly in light of that integrated care system 4th purpose, that explicitly now those are systems charged with thinking about the economic and social development of the places that they work. And I'll finish then just on the limitation. I think even then, the idea that even in those vehicles and even with that promise that the integrated care systems accountable, with the relationship that they have back through NHS England, even with subsidiarity and into DHSC, the idea that can be a vehicle that can on its own carry forward the kind of mission that we're setting out to become a genuine world leader in health and to really get tough on inequalities. I think it's unlikely it can do that. It's unlikely it has the levers to pull. And I think if we were to think that that forum or any single part of government could do it on its own, we'd be missing the kind of core point that's outlined here, that this has to be an institutionalized part of decision-making in every government department, in businesses, in the private sector, as well as in the kind of local government NHS space, that they need to be thinking through what's the health impact of a decision in a context where at the moment we don't even know how much is spent on health or prevention in lots of those departments. So I think there's a kind of counterbalance to it there. So some positives and some places that we need to look at other levers and other dynamics as well.
Thanks, Chris. Sally, I might come to you first. Do weigh in on the NHS question, but I'm also really intrigued on your. I think you were called Mrs. Nanny State at one point. Indeed. So I'd be interested in your take on the kind of relative role of the individual and kind of wider state infrastructure, and how maybe also if you've got examples of when you were able to persuade politicians that being more nanny state than they might naturally be was the right thing to do. Like how have you done that in the past?
So let me start with some data. Children going into primary school, 1 in 10 are obese. By the time they leave, 1 in 5 is obese. Meanwhile, at the moment, if you're born now, you have a 25% risk or chance of becoming obese by the time you're 21. So clearly, focusing on responsibility and personal responsibility and agency isn't working it's getting worse. So I absolutely accept we all have a role in our own weight management, our own lifestyles, but it is more than that. We have to have systemic and structural approaches, and the difficult thing for politicians, and I absolutely get this, is there is no silver bullet. We have to do a multitude of things that each make a small difference that in the end matter. And I laid all of them out in a report, my last report as CMO, that was published in October 2019. Sadly, most of them have not been put in place. Yet we know from the polling that the vast majority of people believe government should protect children, and increasingly people believe government needs to move into these areas systematically and structurally to help all of us. I have to say, I'd be very pleased too. And you know, the evidence when we introduced plain packaging, banning smoking in indoor spaces, the soft drinks levy, is the public welcomed them. The public recognized that what we were trying to do, or what the government was trying to do, was help them make the easy choice the healthy choice. And we have to develop that. And I do think that politicians, given time and watching what's going on, do usually pick up on it. But then the lack of silver bullet makes it more difficult. The problem for politicians is this sort of debate is crowded out, whether by the falling prosperity or COVID or whatever. And what the importance of this report is, it puts it back in there under the prosperity and the workforce issues. What we're essentially saying is see support to people as an investment, not just in improving their health, but an investment in our economy rather than a spend or a drag on our economy. And the NHS has a role to play and tries its best, but we all know it's running hot and that there's very long waiting lists. And even if they get it right, it's not going to do it all. We need systemic solutions. And that's why we are arguing for a national ambition and then laying it into law so that everyone does have to face it and get on with it. I think that'll make politicians' lives, short and long term, much, much easier as a matter of fact. So we want a Health and Prosperity Act that leads through to a committee that actually sets targets, looks at it in 5-year chunks and makes it much easier for politicians to do what they generally would quite like to do. Thank you.
Thanks, Sally. I'm going to come to you in a second, Claire, but I just wanted to come to Oliver first, as a politician by background, and to get your perspective on the challenges involved in kind of the balance between personal responsibility and state intervention on some of these questions.
Yeah, I mean, what I want to say really follows entirely from what Sally said. I mean, she's quite right, of course, that politicians across the political spectrum have recognized for a very long time that it would make sense to make, in her words, make easy choices be the healthy choices. But it doesn't happen very much. There have been moves, but they're sporadic and inconsistent. In the report that she issued some years back, she reflected the views of many of us that, for example, it would make sense to have a significant shift in the tax system so that it taxed unhealthy foods more and correspondingly use the money raised from that to make healthy foods less expensive. This was read and looked at and put on a shelf and continues to be inspected in Whitehall, nothing whatsoever of the kind has happened. I'm in the privileged position of being able to tell you why nothing has happened. Because although I was by that time no longer a minister, some years before that, I had argued with some others exactly for the same ideas. And in fact, we were pretty close in the coalition government of 2010, 2015, introducing such arrangements. When the media advisors arrived on the scene and said, you can't do this. All hell will break loose in the pages of the tabloids. Nanny state will be excoriated and your poll ratings will drop and the opposition will make hay. Despite strenuous efforts to resist this advice, the media advisors won the day. Nothing happened. Now, this is precisely what the institutional framework that this report suggests is designed to deal with. And I just want to draw out the features that do that, which are parallel to the Climate Change Act. First of all, it has to be cross-party, it has to be a consensus. So you remove the possibility for whoever happens to be the opposition to make hay out of the government taking action, because they're equally signed up to the same principles enshrined in the same law. That's exactly what happens with climate change. Different parties can take different views about how to achieve the climate change objectives, but it's quite impossible for them to complain that the government is trying, whichever the government is, whoever the opposition is, for them to complain that the government is trying to achieve those goals because they're enshrined in a law that commands cross-party support and has done since the very beginning. Secondly, the politicians need to have something there which removes the option of doing nothing. It still leaves them with options about how they enact the principles, but they absolutely have to do something because the law requires them to do something, and someone will take them to force and get injunctions to force them to do something if they don't. That's what this report is advocating in relation to public health. And it would have a colossal effect on the way that these discussions go in Whitehall. Because when the media advisors come in and say this is going to be unpopular, the Attorney General will say, well, maybe it is unpopular, but unfortunately we have no choice. We're signed up to a set of cross-party principles enshrined in legislation. Unless you change the law, we have to do something. And if we're going to have to do something, we do this. The last point I want to make is, once you get an institutional framework of that kind, it turns out, first of all, that it isn't that unpopular, as just as Sally has been saying. But secondly, actually, governments under real pressure, in this case from an institutional framework, are quite capable of doing things much more dramatic and much more draconian than the sorts of things that need to be done here. People listening will take differing views about whether lockdowns were a good idea or a bad idea in COVID, but they were very much more draconian than the sorts of things we're talking about, like 1,000 times more draconian. They were done, and they were done with cross-party support. They were actually, at least at the beginning, done with popular support. So the idea that governments actually can't take fairly modest actions to tilt social choices so that they are healthier choices to the advantage of all, the people who are making the choices and everybody else, and which will improve the economic performance of the UK and hence generate more prosperity. The idea that politicians can't do that in government and can't get away with it in public and with public support is wrong.
Oh, I think Oliver may have frozen. You're back, Oliver.
Oh, I'm so sorry. I'd finished what I was really going to say, which is simply that I thought it is perfectly possible for politicians to do these things if the right institutional framework is there, and that institutional framework ought to be of the kind that this report recommends.
Thank you, Oliver. And it's worth saying that I think one of the most successful policies that did go through, has gone through in recent years in this space was the sugar tax, which obviously was put through during the coalition years and has been extremely effective and demonstrates what can be achieved when politicians are brave and push through on some of these things. Claire, did you want to come in on any of those points briefly? And then I'm going to try and fit a couple more questions in. So over to you for any brief remarks on that before we move on.
Yeah, thanks. Obviously, we've talked about COVID a little bit there, and also the government cross-party agreement in an emergency situation. So kind of the government was forced to act right in an emergency. And I think what the report's trying to say is that there's another emergency. It's here, but it's also kind of growing and it's around the corner. So rather than waiting and having to, do more draconian, as Oliver said, actions later down the line, let's do some preventative actions now. I think the other thing is that obviously the level of emergency depends on what community you're in. I've always mentioned the problems in the north. That obviously extends to all deprived people living in all deprived communities, where we've had massive cutbacks in local authority spend, in public health spending, and in terms of the impacts on the voluntary community sector. So when we're looking at civil society to help, then we also need to think about how we can reinvest in that social infrastructure to support health improvement. Thanks.
Thanks, Claire. Great. I'm going to take a couple more questions to wrap us up. Our panelists, we're going to have to be brief because we've got about 10 minutes left. The first one is on the issue of racial justice and particularly post-COVID illness affecting Black and Asian communities disproportionately, concentrated in low income and employment, and what we can and should be doing about that particular issue. There is a great question from Tom Redfern on how do we encourage businesses to do the right thing and contribute towards improving health. And there's also a question on what role can science and technology play in addressing some of these challenges. Sally, I might come to you first. Please do pick up on any of those three, although the one that I know that you've done some really innovative work on in your book with Johnny is on the role of pay and play in businesses. So maybe particularly pick up on that one, but anything you want to pick up on those three questions.
Thank you. So business and the private sector or employers are central to all of this, because the conditions of employment, the support you get matter. And that's why I think we had in the chat someone picking up the NHS as a procurer of services and supplies and an employer. Clearly, all can do a lot. And I think it's very important. In the book, Whose Health Is It Anyway, that Johnny and I published in November 2020, we argued that employers really need to put the health of their employees and the employees' families at the center of what they did and contribute to their local communities. We also argued that we should look at a polluter pays, in the sense that if people are making a profit out of unhealthy foods, but not therefore paying for the externalities, so back to the beginning of the tobacco discussions, then we should think about them making a contribution to what in this report is called a health creation fund, supporting the community in a bigger way where they really have problems and needs. Indeed, we went further, Johnny and I, and said that companies or employers should contribute to their local society and broader, and if they don't play and support in that way, mental health support and everything else, then they should pay a levy into what here we've described as a health creation fund, in order that others can do it on their behalf and make sure that deprived communities are really getting the support they need. So we have thought some of this through. It would be innovative, and I'm sure there'd be a lot of pushback. There still is from tobacco companies. I remember being sued by the tobacco companies alongside the government because of plain packaging. But that doesn't mean it was the wrong thing. Indeed, it just shows we were going to impact them where it would hurt them and thus improve the health of our people. Thank you.
Thanks. Oliver, did you want to come in on any of those questions?
No, I don't think I have anything to add on those.
I think your internet's cut out again, but I think you'd said that there wasn't anything to add there anyway, so that's absolutely fine. Claire, did you want to come in on either the any of those questions and maybe the racial justice element of the inequalities? I don't know if your work has touched on that at all.
Yeah, I think the question was about the impact of COVID on ethnic minority communities and the longer term impacts, I presume was about long COVID, and I've posted a new study that's trying to investigate long COVID to try and understand it better, as well as inequalities in it, and therefore to develop specific treatments, because obviously it's not one thing. There's lots of different potential physiological, mental impacts. But one thing I wanted to add into that was, and it links into what Charlie was saying about the role of employers and businesses, is that we've been doing some research up here with long COVID patients and talking to them about what it's meant for their working lives. And a lot of them reported that they had left the labour market because of long COVID. So again, building into today's report, and in some cases they'd stayed in, but they'd had to work lower hours. But one of the key things that came out of that, between the difference between working less hours and leaving the labour market, is obviously big when we're in the context of today's discussion. And the key difference between those two groups of patients was their employer. Was the employer flexible? Were they supportive? Were they able to implement things? And that did tend to be amongst bigger employers. And we talked to employers as well, and small SME employers were asking for support in occupational health. And I think that comes through in some of the chats as well. And we do need to think about what offer we can give to support businesses who are signed up to this agenda.
Thanks, Claire. And I might ask Chris if there's anything you want to come in on, and then maybe just to say briefly what we can expect from the Commission in the upcoming months. Might be worth taking a few seconds just to mention that.
Yeah, why don't I just touch on the question of business and innovation combined, because I think that's important. And I think what the mission that we set out today, the aspiration, does is it gives a neat way to start thinking about what the contributions of different parts of that whole society approach look like. There's no single entity that can deliver that on its own, and that's the point of the mission, should be so stretching that is the case. And I think that means that once you start breaking down that healthy life expectancy mission by its components, the things that actually drive that up, then you start to see, well, okay, this is where we have problems that are currently insurmountable that we need the mission to catalyze innovation in. And you can start to think about what the partnerships, what the tools are, what the levers are to help make that happen. And you can also see what's incompatible with some of the things that we have in the economy at the moment, and start to think about ways that across and in kind of a level playing field way that you can start to change some of those dynamics as well. So that will be a big focus for us in forthcoming work that thinks about the kind of role of the state, the strategic state, the relationship that it has with business and with civil society, and we'll start to bring some of those ideas forward. In terms of other things that you can expect from the Commission on Health and Prosperity, it's a really exciting programme for the next year. So we'll be thinking across a series of forthcoming interim reports about what the future of health and care services are, thinking both NHS and social care. We'll be thinking about, as I say, that relationship between business and that characterisation of the state. We'll be reporting back on some really intensive deliberative work with people in places to think about what place should look like and how we can make sure that that's hardwired into this vision. And then the big work of taking all that insight, all that research, and compiling it into one single vision for health and prosperity in the UK, something that's really ambitious and that looks forward to the long term, the potential that we've talked about today. will be the work of the Commission moving into early 2024. But I think the moment for that is right. So hopefully that sounds exciting to those that have joined us today. And we would, as a team here at IPPR, love to hear from anyone that's been kind of inspired by anything that's talked about today, or would like to collaborate, share work, ideas, and to work with us on taking that forward.
Thank you very much, Chris. We've hit time. It's been a really fascinating conversation. It's great to see that the work that we've been doing has galvanized such an interesting debate. And as Chris says, we're delighted that you've been able to join us here today and invite you to kind of come with us on this journey as we try and land some of these big policy ideas in the run up to the next general election. The only thing for me to say is thanks to our panelists, to Dame Sally Davies, Sir Oliver Letwin, Professor Clare Bambra, Chris Thomas and Carsten Jung, and thank you to all of you for joining here today. We look forward to seeing you again soon. Take care.